Thank you, everybody, for coming today. I really appreciate your time, and we're hoping to tell you some very interesting things that the Greater Houston HealthConnect is doing in order to expand the definition of what health information exchange can accomplish for a community, in this case, of course, the community of the great city of Houston, Texas. So I'm going to start by talking a little bit about the background for Ethan. So Ethan stands for Emergency TeleHealth and Navigation. It is a program of the Houston Fire Department in conjunction with the Houston Department of Health. And I'll give you a little bit of a sense of the background as to what the purpose of the program is and how they're deriving value from HealthShare as a product. So I want to start just by giving a little bit of an overview of the mission of the Houston Fire Department and the issues that they're up against. Houston obviously is the fourth largest city in the country, 2.3 million people. Very large, obviously, and growing to the point where it's approaching, I think it's going to pass Chicago eventually and become the third largest city in the country. It's also important to recognize that Houston is also an extremely large city in terms of its actual footprint. So the square mileage that makes up the city of Houston is about 30 times the size of Manhattan. So when you think about the area of coverage that has to be covered by Houston Fire Department, it's very significant land area, and it's a challenge. And so here you can see there are about 93, I think, fire stations across the city, over 4,000 personnel, and they actually have, in addition, of course, you think of firefighters, but they've got medical staff that are delivering EMS, emergency medical services, across the city. And you're talking about 1,000 service calls per day, more than that. And you have 84% of those calls have nothing to do with fires per se. It's really about EMS, emergency medical services. So you're talking about over 300,000 EMS calls over the course of a given year. So again, in terms of the state of emergency medical services in Houston, very rapid growth, as I pointed out, soon to pass Chicago. I'm not sure when that's projected, but it's coming pretty soon. And the 900,000 calls per day, only about 27% is the number that I have, are true emergencies. So you've got a very small subset of the time that you roll an ambulance and reach someone where you actually have an emergency situation where that person really needs to see someone in an ED setting. And that's a real serious problem because it's a waste of resources, potentially, and it's a waste of time, energy, money, all of which are strained, especially given the growth of the city and the trajectory of growth that it's on. I'm going to talk a little bit about those things in more detail. So when you think about what the Ethan program is designed to do, the three major goals of the program are, first of all, efficiency. We're trying to reduce the number of times that the units, as they're called, the EMS units, the EMTs, and of course the actual physical equipment of the ambulance are in service, have those units return to service very quickly and be utilized on the cases that are most important. And safety, of course. We want to make sure that we are, to the extent that we're trying to save costs by avoiding unnecessary ED visits, knowing that we're always providing the highest quality of care and that people that need that emergency care are getting it rapidly. And that same rapid response standard isn't in any way diminished by the cost savings that we're trying to get, the efficiencies that we're trying to get through the program. And focus. So you want to make sure that the resources that are available are there for the patients who need them most. It's not just about the people that are making those emergency calls, it's the other folks that are showing up at the emergency room and they have serious emergency medical issues, and you want to make sure those people aren't waiting in line behind someone who has made a call, gotten an ambulance, and arrived at the ED, and they don't even really need emergency care. Those people might be getting in the way of folks that really could use that care. So at this point, what I'd like to do is hand it over to Nick Bonvino. He's the CEO of Greater Houston HealthConnect, to talk about how the program works and what it's doing for the people of Houston. Nick.
Thank you, Lou. Good afternoon, everyone. There we go. Thanks. So as Lou was describing, tremendous volume of 911 calls, crews go out to the scene, and the crew makes an initial assessment of what's going on. And if they truly need to be transported ASAP to an ED, then that's exactly what happens. But if there's a question about that and maybe some triage that could happen, that's where the Ethan call takes place. And I'll describe what that is. We'll show you what that is. But essentially, it's a call center of physicians that will take that input from the scene, and that's where also Greater Houston HealthConnect comes in terms of bringing up that patient's medical history to triage and then disposition, where should they go. and ultimately deliver care at the right venue. That's fundamental to how the program works, and we'll go through some further details about that. So the field units with the ambulances arrive. They're absolutely essential to do a first analysis, but the physicians, and these are actual physicians that work for the Houston Fire Department, they rotate in this call center to taking those calls. And if it is a low acuity situation that doesn't warrant the cost of an ambulance ride from the scene to an ED, we have alternate transportation services that might be a little more efficient in delivering a patient where they need to go. We also, for repeat calls with a similar situation, have an intervention group that can help educate and work with folks that 911 may not be the appropriate reaction to whatever your situation is. And then ultimately, if that is the case, putting them in a place where they can receive appropriate care and a primary care network that we work with. So that's a bit about it. So Greater Houston HealthConnect provides that component of the solution, but the city of Houston and the fire department have contracted with us to actually administer the program. So let me tell you a little bit about our company. We're a not-for-profit, independent health information exchange. Here's Houston, Texas, which, according to my information, actually is the third largest city in the country now. But we cover outside of just the city, but it's Southeast Texas. So the number of patients that we have to uniquely identify that receive care in this area is about 15 million. So here are some of the major facilities, and if anybody's been to that area, there's some pretty large recognizable names, but we've also got the safety net providers, the FQHCs, critical access hospitals, doctors' offices, you name it. Our mission is to connect the entire community so that wherever a patient goes, we're coordinating that care by connecting all the providers together. It's 24 counties, as I mentioned. We've got tremendous number of beds, number of physicians, all of that done with participation agreements on data sharing and allowing, permitting us as a business associate to deliver that information for payment, treatment, and operations. But it's well over 1,200 different venues of care. So think of it as a patient, wherever you go to receive care, your information will follow you and be available to impact decisions that are being made at the point of care. That's what we're all about. So what I just described is our core service line of information exchange. It's a query and retrieve model. Patient shows up at the front desk of a clinic, admitting to a hospital, at an ED, whatever the venue is. That facility will query us, will bring back that information real time, and put it in the clinical workflow of the caregiver that's trying to deliver care so that they don't have to get out of their workflow. It's very convenient, efficient. It's all there to, most importantly, impact the decisions that are going to be made at the point of care. We do the same thing with imaging. So diagnostic images. Query goes out, all available studies, and if caregivers are anxious to take a look at those in clinical quality, they can do it in our cloud. If they want to download it to their PACS, if it's a mammo, they need priors, for example, they can download it to their PACS system as well. Also leveraging this infrastructure, we get these real-time feeds, as I was saying, that allow us to be the hub of all medical information, and what we have is a service line around notification. So in the era of payment reform and taking risk on populations and managing those populations, what we have here is if you are responsible for any type of MSSP, ACO, other health plan type of membership, we can let you know what's going on real time so that you have an opportunity to intervene and manage that population. Further, we've taken all of this infrastructure and all of this data and are making it available for health services research. we have many large research organizations in our community that do all sorts of great work. And the access to data, the ability to identify a cohort with our systems really enables much more work to be done, gathering all of the possible cohorts to a particular study. And then finally, part of Ethan, along what we call that kind of public health, but public health reporting, syndromic surveillance. Got a great experience to share at some point about what happens not in just good times, but also in bad. We had a little bit of rain in Houston year before last. Hurricane Harvey dumped 5 feet, and we were able to use our service and bringing it right into the shelters. No EHRs, volunteer docs, evacuees that they've never seen before, and help them get a background so they can properly assess, diagnose, and ultimately treat these evacuees. So that's what we do day to day. And a little bit of how we do it, right? There's the whole HIE model is, it's a hub model. This represents the entire ecosystem, and we have these connections. One connection gets you connection to all. If I were to redraw this with every provider or every entity, every stakeholder connecting to everyone, you pretty soon get a spaghetti chart. And very inefficient. This is a great way to coordinate care and puts us again at the center, a hub of all medical activity that allows us to do things. But job one, before anybody shares any information about a patient with someone else, we've got to properly identify that patient, uniquely identify them. And again, I mentioned 15 million people, unique people. So the way that works is these, again, real-time ADT feeds into a master patient index. It's HealthShare Patient Index is the InterSystems product. We, last time we looked, have about 15 ADT messages per second going into this file. That's an incredible volume. And clearly that file is changing rapidly, moment by moment. So the guts of a master patient index is the probabilistic matching algorithms that can constantly go through, take that new input, match to existing, and go through and really uniquely identify not just the patient, but then where they've been. So when we need that data, we know specifically where to go get it if it hasn't been stored in the HealthShare repository already. This is something that is hard to do. It takes a tremendous technology from InterSystems, the processes we put in place, and actual people, because with that quantity of patients that we have to uniquely identify, the technology will tell us definite match, definite non-match, but that probable match queue, we have to work that. And we get 100 to 150 matches, additional matches a day just through that extra effort. That's on a region of Texas, 15 million people. How do you do that nationally? Think about that. And is there a silver bullet out there? Anyway, that's how we make the magic happen in identifying patients, then making it available for Ethan as that truck rolls up. So what I'd like to do is just again review. When I said we'd do the administrative aspect of it, running the program, the city gives us a budget, and we manage and administer the program, which really is identifying other participants of ours, healthcare providers, that would like to open up their schedules so that we can plug those in if it doesn't need to go. If the patient doesn't need to go to the ED, what's an appropriate venue of care? And we arrange with our participants to have patients sent to them. They open up a schedule, and Lou's going to take you through the actual workflow. Very cool stuff, real time. And then we also coordinate with transport companies. So if it's not going to be an ambulance ride, we get that transportation scheduled by the physician. If can you make it later today, or maybe less urgent during the week? We've got a schedule at this, and then we'll also schedule a transport from where they are to where they need to be. So overall managing the program as well as the specific technology.
I think this is where I'm going to take over
turn it
and
back
talk a
over to
little
Lou.
bit about slides. Thank you, Nick.
And I must also acknowledge, besides the technology from InterSystems, J2 has been, Lou is the president of that company. He's helped us tremendously, first getting established with the system, and then we've been running this. We'll show the statistics, but we've rewritten it now in a new and improved version, and J2 did that work for us, so we really appreciate it. Great job.
Thank you, Nick, very much. I really appreciate that. So Ethan, and as you look at the screenshots, I want to point out that it's also undergoing an expansion of mission, and it's also going under the brand Synapse as well. So the Ethan Synapse project, which is sort of the next generation of the Ethan program that Nick is alluding to, that is about to go live right now, has a few different steps in the process. I just want to explain that so that it kind of makes sense of how this looks visually to the care team that are at the Houston Fire Department getting that Ethan call from the folks out in the field in an ambulance. So first and foremost, there's a work list feature that lets you see all of the patients that are awaiting triage or who have been triaged out in the field. Again, I think Nick explained this well, but just to kind of reiterate, the idea is that the EMTs, when they go out there and they encounter a patient, some cases are very clearly emergency cases. You're going to get that person immediately to the ED. Some are going to be a little bit more ambiguous, or some they have a pretty strong suspicion this might not really be an emergency case. And in all of those cases, they're actually connecting with the doctor, and the doctor is going to then conduct a video session in order to do triage in real time. And as you know, anyone who's a physician can say as well, there's a lot that you can pick up in a video session that you might not get just from hearing the EMT describe the patient or from hearing the patient on the phone. There's a lot you can pick up from body language and from their affect and from their appearance that might give you a sense of the state that they're in and the care level that they might need in order to be safe and make sure that they're getting what they need from the physician. So this next step in the process, when you select one of the cases, you're then going to be looking to find potentially, let's say that you go through that triage session, and let's say you realize that alternate transport would be a good idea, that in fact you're recommending that this patient go to a clinic. And again, that's a recommendation that's going to be made by the physician. It's a recommendation that, frankly, the patient can accept or refuse, right? The patient could, in fact, refuse the doctor's advice and insist on getting transport to the ED, so that in the statistics that you'll see in a moment, that is one of the outcomes that we track. But assuming that they say, yes, we'll accept that alternate transportation and let me receive care at a clinic instead of at the ED, then there's a facility locator that's going to identify the closest facility to that patient and start to make arrangements for transport. Patient pickup is a little bit of a different thing, and this is a subtlety in the workflow, because if it truly is an emergency case, you're going to provide the patient with options. It may be that they want to go to a clinic right now. It may be that it's after hours or simply not possible to go to a clinic right now, or it may be that they choose the convenience of making an appointment tomorrow, or next day, or whenever it may be, and so their actual pickup location could be different. They could be out at a restaurant when that 911 call comes in, but then they say, you know what, tomorrow I'll be ready, pick me up at my home, and it might be a different pickup location. So that subtlety in the workflow is handled by the system in a very seamless way, and you can figure out where that patient is going to be picked up. And then you're going to arrange for transport. Nick alluded to the fact that there's an inbuilt connection with Houston Cab and the taxi service in order to actually do that. And of course, we want to schedule the patient appointment, and it's a pretty simple, straightforward, and very easy to use scheduling capability within the Ethan application. And when that appointment has been scheduled, the taxi service is arranged. And then you get a confirmation that is explaining the transport details, when that's going to happen, when will the pickup location be, when will the destination be, where will they be going, and so on. So I'm going to just talk a little bit about the impact of the program and what we see in terms of statistics. So I'll start with resource utilization, which is a big part of this. First of all, if you take a look at that table in a lot of detail, and you see that some of the dispositions involve a destination of the ER. Some of them we can actually take them to a clinic that is either an Ethan clinic or an alternate clinic. And then there's also the transport being the other variable. So in the ideal case, we're able to find a way to get someone alternate transport by cab, or it may even be self-transportation. They might drive themselves to a clinic. That's obviously going to be saving the most money and saving the resources. At the top of the scale is the one where we know it's going to be EMS transport to the ER. But you might end up at the ER because you refuse the recommendation of the doctor, and you might say that you're going to take a cab yourself or get yourself to the ER. There's a number of different outcomes. But if you take a look at how those statistics add up, 89% of the time we're able to avoid an ambulance transport, and 13% of the time we're able to avoid an ER visit. And that starts to really add up in terms of cost. So you'll see in a moment, I think before we get to cost, we have a slide that's a little bit about how the units get back into service and how quickly that can happen. So when you look at the stats, there is a study that was done by the Western Journal of Emergency Medicine where they looked at the program in some real detail, and they had a significant sample size. And over that sample size, they found that the median time was 83 minutes when you roll an ambulance and then you go through the entire workflow of getting that patient to the ED. When is that ambulance ready to go out again to get another patient? 83 minutes is the median time. But if you instead have Ethan and you're getting that transport to a clinic, or the ED for that matter, you're looking at a 39-minute turnaround time before that unit is back in service and before you could be serving another patient with that ambulance. So that becomes a very, very significant multiplier on the availability of the equipment and the teams that are doing that EMS work. So this is where we really talk about cost, and each of those dollar signs is shaded in two colors, which gets a little bit comical toward the end, and I'll explain why. You can see how in a traditional EMS response, if it's costing on average about $1,000, that's the darker blue for patient transport, and $1,200 for care in the emergency setting, that's a total cost of about $2,200. In the middle section, you've got the case where the patient care is still taking place in the ED, but we did avoid using the ambulance and you are using a cab instead. There's a significant savings. That dark blue area is very, very small. It's only $20 on average to get the cab ride. And then the tiny little dollar sign on the end, like I said, a little bit comical, is $20 for a cab ride, $200 for the cost of care in a clinical setting, and there's an order of magnitude difference here in terms of the actual cost. So I was going to give Nick the option of doing this slide, but Nick's very shy about, bragging about his organization and all that stuff. So I am going to, on his behalf, talk about Dr. Mike Gonzalez. I really want to call out the impact that he and his team have had. I mean, this is Mike Gonzalez and his team. This is their program. They are the folks behind Ethan. Mike is an amazing champion of this program in terms of getting it off the ground and making it successful, but also, evangelizing why this is such an important thing. And he was kind enough to give us a little bit of his insight into why the infrastructure that Greater Houston HealthConnect provides is so critical. Without the exchange, none of this mission would be really possible at this level of efficiency and scale. And I want to talk a little bit about the technical side because I know some of you are coming here specifically to understand the guts of what is going on here. And for those of you who know HealthShare and know about InterSystems capability, understand that InterSystems HealthShare is a wide range of components that come together to form a complete solution, and different solutions for different exchanges can take different forms and use those components in different ways. But the bedrock of the technology infrastructure is HealthShare Information Exchange. That's where you're talking about the clinical data repository that brings together all this aggregated data from organizations across the community. Nick alluded to that before, coming from many different organizations of different types and different sizes in order to bring together a unified community record of a patient's history that Greater Houston HealthConnect is able to serve up to whoever needs it in the community. And that's the core of what HealthShare does. But on top of that, you've got Patient Index, which is doing the patient mapping. That's the EMPI part of the solution. Also critically important to this to make sure you're always dealing with the information for the correct patient. But on top of that, what I really want to highlight is the fact that I think we're past the point where information exchange, the value proposition for information exchange is about more than simply being able to serve up data and being able to say that we're collecting that data, we have it in one place, we have a source of truth, and we can serve it up on demand. That's something that HealthShare does in its sleep, so to speak, and that's something that we've been doing for more than a decade with this technology. What is really fascinating to me about HealthShare, the reason why we always recommend it to our clients, the reason why we feel like it enables our clients to raise the bar, is the robustness robustness of the platform, its extensibility, its flexibility, its adaptability to use cases that may not have fit within your traditional conception of what an HIE can do. So when you think beyond just those vanilla use cases, and you think about something like Ethan, the fact that HealthShare supports that very robust application development framework, a data model that can be extended to hold arbitrary data elements and arbitrary information to support those use cases, and the fact that it's so easy and rapid a deployment process, the fact that we went from idea to live deployment of the solution in such short order is really a testament to how easy the tools are to use and how accessible and how quickly we're able to get from the wireframe to an actual production application system.
Not to mention the skill of your programmers
well,
and the quality of the work that J2 Interactive does.
Thank you very much. And I will say one last thing. I really appreciate that, Nick. But it's important to recognize Greater Houston is one of those organizations that has done an incredible job not only of delivering this value, but also of building internal capability on the platform. That's one of the things we're most proud of with our HealthShare customers is that it's great that Nick can reach out to us and rely on us when there's a project like this where he wants the extra help, but all of the basic blocking and tackling of operating that exchange, all of the work that Nick's team does to expand the scope, to bring on a new stakeholder, connect a new hospital to the exchange, that's all done within his team. And it's a pretty small team, all things considered, and it's a team that is run under a really, I guess you could say, a tight budget, and within that tight budget, Nick's able to accomplish what he needs to, and that's a testament to the power of the platform, but also the ease with which his staff was able to pick up that learning curve and adopt that and become expert in the technology. So it's never our intent that there be a dependency on a partner like us, but we're here for the stuff that is interesting and these kind of interesting use cases that go beyond the basics. So thank you for that, Nick. I appreciate it.
Well, just to wrap up, the capabilities you see here, I want to shout out to Dr. Mike Gonzalez again. It was his brainchild. We've been working through. You see the impact, the quality of care. You see the impact, the cost and efficiency. I failed to mention in here that the actual claim that's submitted, we also arrange for one of our payers to do the adjudication of those claims. So it truly is touching all aspects of the healthcare ecosystem, but starting with this specific use case. If anybody is interested in their community to have this delivered and deployed, the Houston Fire Department in combination with us, we're anxious to share the wealth. This is a tremendous impact, as you can see by the numbers, and so please let us know if there's some interest in standing this up in your community to really have the impact that we're enjoying down in Houston, Texas. Thank you very much.
Excellent. Nick and Lou, everybody. Yes.